Hello, and welcome to today's webinar on environmental justice and women's health. I am Dr. Barbara Malkus, President of the Board of Directors for the Massachusetts Breast Cancer Coalition, and I'd like to thank you all for joining us today. Massachusetts Breast Cancer Coalition is dedicated to preventing environmental causes of breast cancer through community education, research advocacy, and changes to public policy. I am delighted to welcome today's presenter, Dr. Tamarra James-Todd. Dr. Tamarra James-Todd is an environmental reproductive epidemiologist at Harvard's T.H. Chan School of Public Health and the director of the Environmental Reproductive Justice Lab. Her work focuses on the importance of pregnancy as a sensitive window of consumer product and environmental chemical exposures. She has been awarded the Estrelita and Yusuf Karsh Visiting Professorship in Women's Health for her research in environmental reproductive health and has served on the EPA's Scientific Advisory Board for the Chemical Assessment Advisory Committee, 2 National Academies of Sciences, Engineering, and Medicines committees, and the March of Dimes Environmental Justice Working Group. Dr. James-Todd, I really want to welcome you and thank you for joining us.
Thank you so much for having me, and I'm really thrilled to share some of the work that we're doing here that is very much adjacent to our understanding of how the environment impacts breast cancer risk. Dr. Malkus, if you can let me know if I have appropriately shared my screen.
You have, and I'm going to let you begin your presentation. Thank you so much.
Thank you. So today I'm going to give a little bit of a perhaps slightly different talk than other talks because I want to discuss how environmental justice impacts the women's health. Really thinking about this across the life course, but thinking about how environmental health disparities contributes to some of the health disparities that we see. And to ground us for this talk, I want to start with some definitions. First, I want to make sure that we're all on the same page in our understanding of what environmental justice is. There are many definitions. Today, I'm presenting a definition from the EPA, and that it is really the fair treatment and meaningful involvement of all people groups that is across racial, ethnic groups, nationality, income levels, in not only the development of environmental policies and regulations, but also in the implementation and enforcement of those. And today I'll be highlighting several examples that show that this isn't, we're not in a state yet of having achieved environmental justice, and that this could have real impact on reproductive justice. And a lot of the examples I'll be talking about today are in the reproductive health space. And so I want to make sure that we understand that there are many definitions. This is from the Sister Song organization, and it's defined as the human right to control our sexuality, our gender, and our work and our reproduction. Because I'm talking about issues around injustice, I want to make sure that we have a grounding in the health disparity. So it's not just the differences in health status of a population, but it's that these differences are aligned with social, economic, and or environmental disadvantage. And this is from a definition from Healthy People 2020. And finally, whenever we're talking about issues of injustice and disparity, what we're really trying to frame is not just a description of disparity, which I think sounds fairly hopeless. And as a public health practitioner, I am in fact an epidemiologist. I came into public health really interested in helping people. And the goal in the context of public health is also to achieve health equity. So I want to ground us in this idea that this is really the principle that underlies a commitment to reduce and ultimately eliminate disparities that are really linked to social and other determinants of health. And that's our end game, is to try to really achieve a space of health equity. So I want to provide some examples of differences that we can see within the environmental riskscape. And what do I mean by this? So I mean that there are place-based factors that can really impact risk of disease through either current and historical policies that determine land use, for example. In this context, you may think of something like historic redlining. It could also mean that there's an overburden of toxic and acute or chronic exposures across the life course. It could also mean that there's less access to health promoting opportunities and organizations, and that means that there's less opportunity to actually be exposed to those options that could really promote health and improve health, and that those aren't limited necessarily by just place and time, but that the impact, for example, can be not just to the individual, but across multiple generations, and can really manifest itself in a way that it's not just about the environmental factors, but also can interact with stress and have some additional complication for adverse health. So when we think about this type of work and how environmental factors may really downstream impact health disparities, we have to think about the different upstream factors that may be involved. For example, we think oftentimes in the context of, as an epidemiologist, just about the environmental exposure and the health outcome of interest. It could be that we are looking at phthalates, which are these endocrine disrupting chemicals, or metals exposures, and breast cancer risk, for example. But what about the factors that are really driving the exposure, such as behavioral factors or other social and contextual factors, or the laws and policies that are in place? And so what I'm showing you here is what we like to call the translational epidemiologic approach that we published on a few years ago, where we're thinking about this in the context of where might there be opportunity to intervene. I may not be able, or frankly, I'm unable to change somebody's race, ethnicity, but I may be able to think about what's driving some of those differences, whether those are policies that may be targeting certain groups, or if there are behavioral factors, again, not just thinking about the individual, but also thinking about some of those place-based factors where we've underinvested or disinvested in some communities, and we've placed folks at risk by placing things like landfills and industrial sites in certain communities, and then providing green space and less roadway traffic in other communities. So when we're thinking about this approach, I give you the example here of policies like historic redlining, which date back to the 1930s and 40s, where individuals were not allowed to receive mortgages in certain areas of the cities across the U.S. This was enacted by the U.S. federal government. And many folks don't know that this was actually a spinoff of the New Deal. And really, it was Black and Brown communities, as well as immigrant communities, that weren't allowed to basically be able to purchase homes in certain regions, and those regions were redlined as opposed to the green-lined and blue-lined communities that were predominantly U.S.-born white individuals of European descent were allowed to purchase homes. And in that, what that led to was a difference in wealth accumulation. And so this downstream also led to again, as I mentioned, a disinvestment in these historically redlined communities. So despite the fact that these laws were by the 1960s no longer legal, the disinvestment had already happened. Landfills were put into these lined communities, less grocery store access, more retailer redlining. So we've created a food apartheid situation where there's fewer grocery stores in these communities, more hazardous conditions as far as air pollution with more roadway traffic, highway traffic, and so on. But that also, and I will show you a little data a little later, led to higher or less access to safer products, more lifestyle and health promoting organizations in these communities. And the data that I'll show you shows that this may be contributing to exposure differences with respect to biomarker data, for example, these endocrine disrupting chemicals, and then really contributing to health disparities like what we see with respect to breast cancer mortality, for example. So when I talk about environmental justice and more specifically environmental health disparities, I like to really think about this in the context of understanding what are the necessary conditions for an environmental health disparity to exist. And there are three. One is that there is an association between the less advantaged group, and that could be, I mentioned race, ethnicity, but it could be socioeconomic status, it could be immigrant status, it could be living in a rural area versus an urban area, it could be gender differences as well. So it could be a host of things that put, uh, based on issues of what we how we discriminate in various settings and social context, and their impact on environmental exposures. So the second thing is that the second condition, rather, is that there's an association between the less advantaged group and the health outcome that we're interested in. So again, it could be we're looking at socioeconomic status, for example, and say, for example, breast cancer mortality. And then the third condition is that there's an association between these environmental exposures that we're looking at and the health outcomes of interest. Again, in this case, since we're speaking specifically about environmental exposures, it could be these chemicals that I just mentioned to you, which I'll go into more detail about, and breast cancer risk. So my lab, the Environmental Reproductive Justice Lab here at Harvard Chan, spends a lot of time thinking about different sources of exposure, particularly as it relates to environmental health disparities. And one of the areas that we spend a lot of time thinking about is beauty justice. In fact, we have a podcast that speaks to this issue. And oftentimes when I bring this up, people are like, what does that have anything to do with environmental health risk? And so here in the United States, we have a very Eurocentric standard of beauty, meaning that lighter skin, straighter hair are often things that we more highly value in the context of beauty. And there's reasons from an economic perspective, from a social acceptance perspective. There's been numerous studies that have shown that folks who have straighter hair, folks who are taller, so on, have an advantage economically in that and professionally. So when you think about exposures, it's no wonder that the average woman, for example, is more exposed to many of these chemicals, even compared to the average individual who identifies as being a man. And what I also want to note here is that there are differences in who has the ability to achieve those beauty standards and how many products it may take to do that. And there's also age differences that exist. So the relevance of that, even in the news most recently, is that these chemical hair straighteners, for example, that are being used are linked in several studies to higher risk of uterine cancer in Black women. Indeed, there is a lawsuit right now that is quickly becoming a class action lawsuit. Multiple states are involved now in really trying to understand the impact of these chemical hair straighteners or hair relaxers as it relates to cancer risk. And so this is a hot topic in thinking about the role of beauty justice as kind of a subset of environmental justice and health disparities. So in our lab, we spend a lot of time thinking about a class of chemicals known as phthalates, and these are endocrine disrupting chemicals. They are able to perturb the normal functioning of our body's hormonal systems, of which certainly breast cancer is a hormone-mediated disease. And these chemicals are found in personal care products, diet and food packaging, and medical tubing, medications, and plastics. And I mentioned to you that we are particularly interested when we're thinking about environmental health disparities, about making sure that those three conditions are met. So I want to show you that this first condition is indeed something that is met here, in that we see differences by gender. This is data from the National Health and Nutrition Examination Survey, U.S. Representative sample of the U.S. population. And I'm showing you concentrations of different phthalate metabolites, which is what we measure in urine. We believe that this is the active it becomes the biologically active ingredient, or that can really impact health. And I'm also showing you this by race ethnicity. And so again, women have higher concentrations, and then those who identify as African American and Mexican Americans have higher concentrations of these phthalate metabolites, many of which are um, for example, MEP, or monoethyl phthalate. I can only show you a tenth of this because we're so highly exposed here in this country to this particular chemical, but its use and its ability to kind of hold fragrance into products is one of the key usages for this. Parabens are also fall into another class of endocrine disrupting chemicals. They're used for their antimicrobial properties, and they're also used in personal care products and food and diet. And so here I'm showing you again data from the National Health and Nutrition Examination Survey. And worth noting, in addition to showing you by race ethnicity, I am showing you by age. And so even as young as ages 6 to 11, Black girls have much higher concentrations of these two different types of parabens. And so, how does that translate? And in our earlier research, where we were looking at the association between some personal care products, specifically hair products, we found associations with earlier onset of age at menarche, or when a girl starts her period, which is a risk factor for breast cancer. And this was certainly something that we saw was kind of mediating the association between racial ethnic differences and age at menarche. I'm not going to go into that story today, but I did want to kind of highlight that. I often have folks ask me, like, well, that data is fairly old. What about more recently? And so we've been looking at the time trends of chemical exposures in that same data set, the National Health and Nutrition Examination Survey. And we looked at this from 1999 to 2016. And what I want to point out here is that for the most part, in more recent years, 2013 to 2016, down here, you see this decline, with the exception of the green line, which represents the non-Hispanic Black population. Part of this is an awareness of creating products that do not contain phthalates in them and using replacement chemicals, but it's worth noting that this might not be happening equitably. And so what are the implications for potential differences in product ingredient inclusion in products that are marketed to different populations and groups of individuals? And I would say that why that matters is that when we look at the distribution of chemical exposures, and so this is looking at two different populations, we could think of that as a higher income group and a lower income group, or we, in the context of what I just finished speaking about, we can think about that in the context of a non-Hispanic Black versus a non-Hispanic white population. And just worth noting that individuals, if we really believe that higher exposure to some environmental factor is of importance, then we shouldn't be surprised if we see higher concentrations of these, in a difference in the distribution. So again, if the non-Hispanic Black population represents this kind of turquoisey colored, this is their distribution, and the non-Hispanic white population, their distribution of those chemicals looks like this, then we may see differences in how these affect biology, because the concentrations on average, there's little overlap maybe, and how they're impacting health may differ. So I want to give 3 examples of an environmental health disparity that can really be contributing to environmental injustice issues. And to ground us in these 3 examples, I'm going to be talking about 2 forms of endocrine disrupting chemicals, but phthalates, and then I'll talk about PFAS shortly. And I'm talking mostly about pregnancy health disparities. And you may say, what does this have to do with breast cancer? So it turns out that pregnancy and postpartum health really do impact later life breast cancer risk. And while the data are complex, they're very complicated in how those associations play out with breast cancer. What we do know is that many of the same underlying risk factors that impact or that are associated with gestational diabetes, for example, hypertensive disorders of pregnancy, maternal obesity, and preterm birth, are also linked to later life sequelae, including increased weight gain, more insulin resistance, and cardiovascular disease related outcomes, all of which are linked to breast cancer. So while there are some studies that suggest that there, for example, are associations between gestational diabetes and breast cancer, while in other studies suggesting that there might not be, what we do know is that gestational diabetes is associated with insulin resistance. And in later life, insulin resistance is associated with breast cancer risk. And likewise, um, higher gestational weight gain and more postpartum weight retention, for example, is associated with obesity in later life, which is also associated with breast cancer risk. So it's this complicated situation, but certainly these pregnancy and postpartum factors are linked to breast cancer risk. So in this first example, I want to show you that, again, these conditions of an environmental health disparity are indeed met. Here I'm showing the association between a less advantaged group and health outcome. And in this case, what I'm showing you is that, for example, Black individuals are 50%, have a 50% higher risk of having a preterm birth. This is data from March of Dimes. Indigenous individuals also have an increased risk of preterm birth. I'm showing you data now linking the association between race, ethnicity, and urinary phthalate metabolite concentrations. Again, these chemicals that can be used in personal care products as well as food packaging. The 2 phthalate metabolites I'm showing you here, monobutyl phthalate is a metabolite of dibutyl phthalate, which is commonly found in things like nail polish, for example, and monoethyl phthalate, a metabolite of diethyl phthalate, is again this kind of fragrance associated phthalate. And I'm showing you non-Hispanic white, non-Hispanic Black, and Hispanic racial ethnic groups from the Life Codes pregnancy cohort, where we measured urinary phthalate metabolite concentrations at 4 time points across pregnancy. And you will note that there is a statistically significant difference between the Hispanic population and then in both the non-Hispanic white and Black populations across pregnancy, where Hispanic individuals had significantly higher concentrations of this particular phthalate. And likewise, we see these same associations for both the Hispanic and the non-Hispanic Black population relative to the non-Hispanic white population. So again, across pregnancy. What is interesting is that you'll note this decrease that's happening with the Hispanic population in mid-pregnancy. And it's worth noting that we see that there are changes in the sources of the exposures, for example, personal care product use, that might be driving this. So what that tells us is that's intervenable potentially. Like I may not be able, I can't change someone's Hispanic ethnicity, but I may be able to intervene to reduce their phthalate exposure. But what does that have to do with preterm birth? So this is data from a pooled analysis. This is a recently published study where a number of different cohorts that represent about 6,000 individuals. And what I'm showing is that these butyl phthalates, folks who had higher concentrations of butyl phthalates and then several other phthalates, had a higher risk of preterm birth. And this is after adjustment for a number of factors. It's worth noting that we have done an additional analysis where we actually looked to see what would happen if we reduced the chemical exposures to that is closer to the non-Hispanic white group. And what we found was that in doing that and kind of doing a hypothetical intervention in this case, we would be able to significantly reduce the risk of preterm birth. So this really, again, speaks to the kind of seeking health equity and what are the things that we might need to do in thinking about environmental health disparities and environmental justice issues. So, like many investigators, and this is actually, I think this was a very well done study, Michael Bloom and his colleagues looked at using a data set in South Carolina, what were the differences as it related to potential biological differences and how these chemical associations with preterm birth might differ by Black and white individuals. And why I highlighted the monoethyl phthalate again, this chemical associated with fragrance, is that the purple represents the associations in the Black population, whereas the white shows associations in the Black population, again, as it relates to preterm birth. And there are differences. This gray line that you're seeing here is when the white population looks protective, and in the Black population, this looks like it's above this gray line, or it's a risk factor, and that kind of harkens back to the Black population had much higher concentrations of this chemical, and so the question being, what is driving that? So one thing could be that there's differences in stress. Ferguson et al., Kelly Ferguson's down at NIEHS, and she looked at these associations, and she did find that folks who had a reported stressful life event of any sort had a much higher risk of preterm birth. But the question becomes, like, kind of what else might be driving that? Like, I can develop an intervention that is based on stress. I should probably do that. But there might be other things that really are driving the chemical exposures, and what are the upstream factors, say these things that fall into these various bins. Again, I should note that these blue boxes down here are just examples. This is not at all an exhaustive list, but might there be dietary or product use factors that are driving this that I could really, again, intervene upon, do something about? So we looked at this, and we looked at racial ethnic disparities within that same study population, the Life Codes pregnancy cohort, and we do see differences. We see that both the Hispanic and non-Hispanic Black population used more perfume, they used more nail polish, the non-Hispanic white population used more cosmetics, but these differences may drive differences in chemical exposures. When we get to kind of more culturally specific product use, things like hair products, we see also these very striking differences for things like hair oils, hair lotions. And I mentioned earlier that we were really interested in understanding this as it related to age at menarche. We were one of the first studies that published on this, finding associations between hair oils, for example, and breast cancer risk factors like age at menarche. So again, might this be partly driving this? And so to kind of proof of concept of this, we want to understand whether or not product use was associated with higher chemical exposures. And so for this, we use data from the ERGO study. It's a Boston-based cohort study. And what I'm showing you is a heat map. So the red kind of indicating higher percent difference, and the purple kind of representing lower percent differences for users versus non-users of these products. And so if you note here, when we look, for example, at nail polish, folks who were nail polish users had 80% higher concentrations of this particular phthalate metabolite, monobenzyl phthalate. Folks who were hair oil users compared to non-users had monoethyl phthalate, again, this fragrance-related phthalate, that were 125% higher. And so again, like real differences in concentrations of these chemicals that are known to be endocrine disrupting chemicals from products that are available, consumer products that are available just, out on the shelf. And so in the context of, well, these things they don't just contain phthalates, they contain, many different chemicals. In fact, if you were to go home, look at the back of one of your personal care products, you might note that it contains dozens of different ingredients. And so we were interested in understanding hair products, for example, as a mixture and their hormonal activity. So we partnered with Lisa Connolly at the University of Belfast in Ireland, and she ran these hormone receptor assays. And it was, you know, interesting to note that many, if not all of these products, none of these had no response across the board. Each one of them were able to operate as either an antagonist, partial agonist, or agonist of some of our main hormone receptors, of which many of these are important and critical to breast cancer and breast cancer risk. So going back to just preterm birth, those same hormones are also important for preterm birth and labor and parturition. And it's worth noting that when we looked at hair product use, what we found was that daily users of hair oil specifically delivered 8 days earlier compared to folks who did not use these products. Like, there are very few things that really are associated with an 8-day earlier delivery or delivery, in that kind of magnitude of difference. And while that may not seem like a lot, it actually, from a clinical perspective, it is. We published this work with clinicians, obstetricians specifically. So, thinking about what we might be able to do. In this case, it's late pregnancy. So maybe we can, recommend that folks reduce their usage of these hair oils, which are oftentimes very fragranced products, and that could have some implications for their risk, of later life conditions that are linked to preterm birth, such as breast cancer. We also saw that among folks who used hair oils daily compared to non-daily and never users, this shift in birth weight. So the folks who used these products across pregnancy, particularly in late pregnancy, on average, had infants born 300 grams lower in birth weight compared to folks who did not use these. And I just want to note that what's really happening is not just a shift in the median birth weight, but all, in this case, sex-specific birth weight for gestational age, Z-score, but it's also this thickening of the tail. So there were infants that were even lower in birth weight than that. And so that's really concerning. And again, birth weight has a complicated, but an association with breast cancer risk. So if we go further back, I keep talking about these upstream factors, and I think it's worth noting that it doesn't just stop at the individual level. It's what individuals have access to. So we are currently doing a study looking at place-based factors that are linked to the ability to purchase safer products that do not have phthalates or parabens, some of these other endocrine disrupting chemicals in them. And so here in the Boston area, there are 24 different neighborhoods. This is actually from a cut of our data that we published on our environmental racism story map that is available on Harvard Chan's website. And I'm just showing you this from 8 different communities here in the Boston area. We now have done 20 of the 24, have over 30,000 products. I believe this was at the time around 12,000 products. But what I'm showing you is in the Boston area, one of the communities, or the community that it has the highest percentage of non-Hispanic white and also happens to have the highest income level, is downtown Boston. And compared to, say, for example, places like Roxbury, Mission Hill, Dorchester, actually Harvard Chan sits over here in the Mission Hill neighborhood. But that finding safer products, like most of the products were more likely to contain a higher hazard score, so 60% increased risk of a higher hazard score in communities of color and lower income communities. And that included having a higher percentage of products that were leave-in in these communities, which means that people put these products that have these more harmful ingredients on their hair, their scalp, which can readily absorb things, and then they put it on again and again without washing it out, and so real implications for health risk. So transitioning to the next example, phthalates and gestational diabetes. It's worth noting that, again, complicated relationship between gestational diabetes and breast cancer, but certainly shared risk factors of insulin resistance, which is certainly linked to breast cancer risk. And when we look at gestational diabetes risk, this is kind of step one, or showing this association by um, these social contextual factors and the outcome of interest. What I'm noting here is that um, there's often times where folks will say, well, the Asian population and the Hispanic population have a much higher risk. Perhaps the reason why the Asian population has a higher risk of gestational diabetes is due to this beta cell polymorphism, and there's a lot of hand waving about this in that case. Except when you look at this data, which comes from Kaiser Permanente, Northern California, where in addition to looking at race ethnicity, they've also stratified by place of birth. And if you look closely, there's striking differences here. So, if what's driving the difference within the Asian population is really due to some sort of genetic or beta cell polymorphism difference, that doesn't make sense. There's certainly an environmental component here because genetics just simply don't change that fast. And so one of the other things that we wanted to look at, again, this is data from the ERCO study, the association between this environmental exposure here, phthalates again, and gestational diabetes risk. And I'm showing you that there appears to be an association. The significant association was this impaired glucose tolerance, which is kind of a subclinical form of glucose intolerance in pregnancy with a twofold increased risk among those who have the highest concentrations of these butyl phthalates or mixtures. And butyl phthalates, again, found commonly in things like nail polish, but also in foods and other things. So in a lot of studies, what they'll do is they'll stratify by race ethnicity, and that's kind of the end of their assessment of environmental health disparity. Is there a difference by a social factor like race? And here I am showing you that there is. The only group that had an association between these butyl phthalates and other phthalate metabolites was the Asian population. This was not seen when we were looking at pregnancy glucose levels from gestational diabetes screening tests. This was not seen in any other racial ethnic group. But what else might be driving that? And so we did an analysis where we were looking at immigrant status and acculturation measures as it related to urinary phthalate metabolite concentrations using that data set that I mentioned earlier, NHANES, a representative subset of the US population. And you see these differences where again, this fragrance associated phthalate metabolite. US born individuals have much lower concentrations than those born outside the US. And then among those born outside the US, you see this decrease in concentration of this chemical with longer length of time in the US. For some of these, you still see these differences among U.S. born versus folks who were born outside the U.S. with a little less monotonic associations or kind of associations dipping down, but certainly there's something there. And so the question is, what structural factors might be really driving that difference? And one thing to look at, as I mentioned, is we saw these associations with butyl phthalates, and butyl phthalates are, again, if they're in nail polish, who's most exposed to nail polish? Well, perhaps nail salon workers. And it turns out that when you look at the demographics of nail salon workers, these are folks who are predominantly Asian, identify as female, are of reproductive age, born outside the US, and one of the most predominant places that they are born is Vietnam. And so when you're thinking about who's at risk of risk, folks, I think sometimes we often like to think that we got to choose what profession we went into, but there are structural barriers that may prevent individuals from going into their desired career or workplaces, and that may silo them into specific workspaces that may overexpose them to chemicals and other environmental risk factors. And so what might we be able to do about that? Again, in this idea of environmental justice doesn't just mean that it's within a neighborhood or community, it might mean that we may need to intervene in the workplace or workspace, providing better laws, ventilation, and other work-based protection guidelines. Okay, so I'm going to end with this example of PFAS and maternal adiposity. And since we're pivoting into a different chemical class, I want to make sure that folks are on the same page. PFAS are sometimes called forever chemicals. They're linked to a variety of adverse outcomes. And what is interesting about PFAS is that they're a hot topic right now. I'm sure many of us have heard of these. And in the scientific literature, what that's meant is that the publication rate, or the number of times that we're now investigating PFAS, has increased more than 40-fold, just based on publications alone, between 2011 and now. So this is indeed a hot topic, and rightfully so. There's so many communities that have been contaminated by these chemicals, which come from a variety of sources, paint, as well as exposure to things like Teflon pans, food packaging, importantly water, but also thinking about the dermal sources of exposure. It can include cosmetics, and also importantly, thinking about work-based exposures. Firefighters, for example, are highly exposed to these chemicals. And so their impact on health continues to kind of emerge, where we are seeing associations with a variety of not just pregnancy, but other health-related outcomes. And historically, folks have thought that, exposure seems now to be increasingly established as being ubiquitous, and that there are no disparities with respect to PFAS. Except there is emerging data that that is not wholly true. It depends on your location, on where you are. So, in looking at this data that comes from a multi-site study, what you see here is, for example, if you live in Southeast Michigan, total PFOS, so one of the types of PFASs, among Black individuals is much higher compared to non-Hispanic white individuals. And that's not necessarily true for another type of chemical. Here in the Boston area, PFOS is much higher. It's significantly higher in the Black population than it is in the Hispanic white population. And so there's real concern about thinking about these equity issues, because one of the challenges that we have is that if water, for example, is one of our major sources of contamination or exposure, rather, to these chemicals, what communities may be able to more easily remediate this compared to other communities may indeed be of concern. It's also, since I'm talking about maternal obesity, I want to share with you this idea, this concept of that when you're looking at disparities in weight related risk distribution in the context of pregnancy and postpartum, there are real racial ethnic differences. So while the populations may look similar in early pregnancy, here this is represented by T1 here. So white, African American, and Hispanic populations may look fairly similar. By the time you're getting to the postpartum period out here, you actually see that there is a bigger distribution in folks who both retained a lot of weight and also had a high BMI. So that's represented here by the green bar. And so folks who had a high BMI to begin with, and then went on to retain a lot of weight following their pregnancy, are folks who are much more likely to be obese in later life, which is, of course, a risk factor for breast cancer. So that's of real concern. And so when we're looking at the association between PFAS chemicals and maternal weight from pregnancy on out to 3 years postpartum, it's worth noting that we found associations. This is data looking at Project Viva, a pre-birth cohort here in Eastern Massachusetts, and we see associations not necessarily with gestational weight gain or even 1 year postpartum weight retention, but we see these associations, really emerge for at 3 years postpartum. In other words, longer term weight retention is a real issue here, and that these chemicals may be really disrupting what is called a metabolic reset, or the ability to kind of return to a normal metabolic state, which is inclusive of being able to return to your pre-pregnancy weight. So we also recently looked at this beyond that 3-year time period, now out to almost 20 years following the pregnancy. So this is looking at pregnancy PFAS exposure. And unlike phthalates, I should also note, phthalates are these non-persistent chemicals. These are chemicals that, while they may be metabolized and rapidly excreted from our bodies within hours, we may be repeatedly exposing ourselves through the use of personal care products and other things. With PFAS, these are persistent chemicals. So, this is why we're looking at pregnancy and then looking out, semi 20 years down the line, for example, and we want to know, is there an association with adiposity measurements? And so we see, for example, again, those PFOS, PFOA being associated with higher body mass index, waist circumference for some of these, waist to height ratio, and then also mid upper arm circumference. We saw a number of other adiposity measurements also being associated with this. So, thinking about this, like what, it's how is it that these pregnancy factors and these exposures, again, it really might be this metabolic reset issue that really could be plaguing folks' ability to return to a normal weight. And without that return, they're sent on a trajectory to having more adiposity. So when we circle back to this kind of big picture of like, how does this speak to things? How might we do something about this? We need to be able, in the context of environmental justice, to really start asking these more upstream questions, because that's where we'll have an opportunity to intervene. When we are thinking about, for example, the PFAS story, um, it's not as simple as, oh, maybe there are no disparities. It's maybe dependent on place and who has access to safer water, whose infrastructure or resources may be able to remediate those exposures more readily. What communities have we invested in, and what communities have we disinvested in, for example? Because at the end of the day, we're really trying to achieve environmental justice and reproductive justice. And so we're really trying to move from a state of kind of like, oh, but we've done the same in all communities, or equality, to really thinking about equity. And then for the justice piece, we've got to remove the barriers. And there's even this idea that it doesn't just stop with justice, it's who we have seated at our table, recognizing that there are experienced experts that need to be at the table, people who belong to the communities that we are trying to serve and work with. And so it's even beyond justice, but thinking about inclusion in the context of this. So some of the things that we're doing, strategies for thinking or about achieving health equity, is that we are running a number of interventions and educational studies, one of which is a clinician-based intervention improving environmental health literacy. Environmental health is not taught in medical school, and so we're leveraging and taking an opportunity to partner with the pediatric environmental health specialties units here in Region 1 to design we've designed rather and launched an environmental health literacy training for obstetricians and other women's health professionals to ensure that clinicians know how to answer questions about environmental risk factors, particularly endocrine disrupting chemicals, and health outcomes that are linked to pregnancy health and the health of individuals who have been pregnant across the reproductive life course. We've also launched an environmental justice summer camp. We've partnered with Bethel Social Justice Institute and the Boston Nature Center to launch this camp. It's never too early to start learning about environmental justice, and these kiddos were super eager to learn about this. They designed their own research questions, utilized the Arnold Arboretum here in the Boston area as a living lab, and really got into the weeds of understanding the impacts of environmental justice and being able to identify solutions to these problems. It's been terrific working with them. And then finally, we launched the Beauty Plus Justice podcast. This is available on major podcast sources, and it's really showing and highlighting the impact of these beauty and justice issues on women's health from different perspectives, ranging from the clinician perspective to historian perspectives, to even cosmetologist perspectives, and then community members as a way forward. This is a little bit more about that environmental health literacy and healthcare professionals workforce. It's a video series that is where we are really trying to improve, as I said, environmental health literacy. And then we also created an environmental racism story map that I mentioned, and that won runner-up for a national award this past year through the ESRI organization. And we get out into the community and do a lot of work around making sure folks are informed and educated around environmental risk factors and health. Lastly, I think it's really important to contribute to national reports. The guidance for PFAS testing and health outcomes was a major undertaking, but has been an important, I think, document to really help inform how we can do a better job of ensuring that folks who have been exposed to PFAS receive the needed clinical care that they might need, including testing. And in this report, we did note that breast cancer showed limited suggestive evidence of being linked to PFAS chemicals. Um, I will just end with the importance of, doing a better job of assessing our exposure, thinking about how these upstream factors or mediators can really inform even our interventions, and that there are different levels in which we might be able to look at that, both at the government level to the individual levels, the macro and micro level factors, that those things may interact with other things like stress, and that we need to do more qualitative work in combination with quantitative work, also known as mixed methods, and think about strategies for really doing interventions. It is not enough to just document difference. We really do have to start designing interventions and testing their effectiveness in the work that we're doing, and thinking also about the role of basic scientists and being able to understand the mechanisms that are at play. As I mentioned, these differences in distributions may lead to differences in biological effects that are not due to, for things, for example, like race, which is a social construct, but it really may impact biology because of the different exposure patterns. Because at the end of the day, we want to go from a model that looks like this to a model that looks like this. So I will end there. I would like to thank my team of really amazing investigators, students, postdocs, our staff, and our funding organizations. And with that, I will open up for any questions.
Thank you so much, Dr. James-Todd. That was really a fabulous presentation, chock full of information for our webinar participants. And I want to invite anybody who may have a question to post that question in the section of your panel that says questions. Please don't put it in the chat. I may miss that, but I'll definitely be monitoring questions if you have a question for Dr. James-Todd. And while we're waiting for people to type those questions in, Dr. James-Todd, could you talk about how we can really reduce our exposures to these consumer product chemicals? What is it that the average person should be looking for, and what should they be doing?
Yeah, so I think one goal that I suggest to people is, I love perfume. I love fragrance, and I think we oftentimes, I was relaying to a friend just the other day. I was like, even the idea of like what feels slash smells clean. Um, we often kind of equate it with like lemon or citrus smells, but being cognizant of that the fact that many of the fragrance products do contain things like phthalates or phthalate replacement chemicals. So like sometimes something will say phthalate free and they just replaced it with, some other replacement chemical that we are actually finding being linked to these insulin resistant measures as well. So, looking to reduce fragrance, even if you can't go completely fragrance free, reducing it. Also, using some of the amazing apps that folks have come up with recently, more recently, like the Detox Me or the EWG Skin Deep app, where you can have it on your phone, scan a product. Some of the apps will provide you with an alternative if it is something that appears to like have a higher risk score, more toxic ingredients. So kind of informing yourself about things that are right at your fingertip that you can use when you're in the store, to just being a bit more cognizant. Some folks have even gone as far as like do it yourself. I'm not there yet. um, I just don't have the time, but certainly if you have the time and energy to do that, feel free to do so. And then I think it's also getting out there, and I think the more folks really speak to this issue and really try to get policy changes. We did have a recent policy change I did not mention around this. It had not, policies around what's included in consumer products, particularly personal care products, had not changed since the 1930s. Um, Recently, there was an update to the purview of what the Food and Drug Administration can regulate. So there are some changes that just recently in the past month or two, if you will, a few months have changed. But that's even there, it's still somewhat limited. And so I think the more voices, the more action, writing to your policymakers and so on to really try to get improvements made around this will be of benefit.
And if you would, Dr. James Todd, it's not really necessary the cost of the product that determines the chemical makeup, right? You could be getting a very expensive product that is loaded with phthalates, and at the same time, you could be getting a product at your local uh, Walmart that also has the equivalent exposure.
We were really interested in that because a lot of pushback that I get, particularly in the context of this beauty justice argument, is that, the safer products are more expensive. So we were interested in that question when we did that place-based analysis, to know is that indeed the case? And while we did see some association, the fact of the matter is that it wasn't as strong as we thought it would be. So yes, there are products where you can spend a ton of money on it, it still could have, harmful ingredients in it. And likewise, the other way around. The challenge, I think, is that um, this argument often can get conflated with thinking about communities of color, and there the folks who make this argument, well, the reason why more harmful chemicals are found in products marketed to communities of color is because they won't pay for it. Well, that start debunking that myth. Actually, a much greater share of personal care product household expenditure occurs within the Black and Brown community than the non-Hispanic white community. It makes up a greater share of the market. So it's not true. Like, people will spend money on products, but it's also, I think it's also continuing to make sure that everyone's aware, and that folks aren't targeted, you know, in a way that really puts them at risk.
I loved when you said environmental health literacy. I think that certainly captures for all of us what as we come into adulthood and we're purchasing products, understanding what is in our products and having that level of awareness with respect to our own environmental health and the environmental health of others. We did have a question that I've heard this before, and it's of great concern because there were studies that did link aluminum with higher incidence of breast cancer. So is the aluminum in deodorant a great contributor to breast cancer as an environmental factor?
Yeah, I too, Dr. Malkus, heard of this as well. And I'm not, I'll be honest, like, I haven't followed up on those studies to ensure that I know that literature nearly as well. I've tended to not look as much at metals, although we are actually doing more of that work with our Superfund Research Center. So I think it's an important question. My recollection of those studies was that the initial studies occurred some time ago. So I'd be curious to see, just based on formulation changes that have occurred. You even see on the
Mhm.
market these days aluminum free. Um, what else did they use then? And what is the risk there with that?
And certainly very highly scented products. So that
Absolutely.
may also, and the consistency may be associated with parabens. So some of the chemicals you mentioned today, plus actually looking at that earlier research around, product use and indication of increased risk due to exposure. I think
Absolutely.
we have time for one more question. I think it's a really important one, and that is, if for our healthcare providers, patients, what should they be learning about? How do we have our healthcare providers be more environmentally health literate? And then what should they be counseling patients to do or not to do depending on their health concerns?
It's a great question. And I think, there's a real opportunity there. Healthcare professionals are, they are the key stakeholders, or, as far as like health communication to the lay population. We absolutely need them to be well informed. And yet the fact that environmental health is not a concept taught in medical school is quite problematic. And so when I speak with my colleagues about this, even, we have resources like the Pediatric Environmental Health Specialties Unit, but they're underutilized. And so, it's a space where folks can go, clinicians can go, nurses can go and ask questions about these topics. But if you don't know to ask this, it's an issue. So I really think that there needs to be increased education and awareness that could be done through continuing education courses. Um, you know, what you all are doing here, with, providing educational opportunities, and hopefully down the line, eventual inclusion of the importance of environmental health and understanding its impact on healthcare. Because, clinicians won't feel comfortable counseling a patient if they don't know the answer to that question. And that has real impact on health. So I'm hoping that through interventions and through the work that you all and others are doing around continuing education, that we will really make some strides in that area of environmental health literacy, for the clinical community.
On behalf of myself, MBCC's Board of Directors, and Cheryl Osimo, MBCC's Executive Director, I want to thank you, Dr. James-Todd, for this very informative discussion today. And I want to thank all of our many listeners for joining us. For those interested, the recording of this webinar will be made available later today on the MBCC website at mbcc.org. Have a good afternoon, and thank you again, Dr. James-Todd.
Thank you so much for having me.